All right, this presentation is about heart failure. And like it says on the screen, um, most of this stuff is just literally copied from the lecture, and I'm just presenting it so that I can try to synthesize it and retain it. And yeah, and the nice Zoomer speech right here, I really hate it. I don't like it at all. Anyway, so what is heart failure? It's actually a clinical syndrome referring to the heart's inability to generate sufficient cardiac output, which is stroke volume times heart rate, to meet the metabolic demands of your organs. Or it can by dramatically increasing pressure, which also results in structural remodeling and some impairment of the general function of the heart in terms of ventricular filling and ejection fraction. Um, there's also not really any reference to any specific numbers necessarily, or functioning, or cause. Um, this is also a very concerning thing to know about simply because of the numbers. As you can see, 65 million are affected, and 1 in 5 people over 40 will develop heart failure, and it's a huge burden on the system as a whole, costing 33% of total Medicare costs, and 6.5 million hospitalizations. And you can see the prognosis is very severe with very high mortality, as you can see from the numbers here. So there's two types of heart failure. There's just a lot of classifications and staging of heart failure, but as far as the structural definitions of heart failure, there's left and right, obviously, because they are two pumps kind of providing two different functions, but they work very similarly. But left side heart failure is typically what you're going to see. It's the most common heart failure. And the causes are from ischemic heart disease, hypertension, aortic and mitral valvular disease, and some other myocardial diseases, whether they be genetic, infection, or autoimmune in origin. Um, so, right sided heart failure, this is not really going to occur by itself typically. Most of the time, it's occurring because of left sided heart failure, just because of the backup of fluid from the left side failing into the pulmonary system, and then that creates added pressure for the right side to pump against, and that results in right side heart pressure or right side heart failure. But you can have right side heart failure in isolation, like in cor pulmonale, due to pulmonary causes like COPD or a pulmonary embolism that causes pulmonary hypertension. And then, yeah, these are the other causes: a left to right shunt or chronic thromboembolic pulmonary hypertension and ARVD. And also, so here's what it looks like anatomically. This is going to be your left-sided heart failure. This is your right-sided heart failure. You can see the huge thickening of the wall on the left side, the left ventricle, and then as well as the left atrial enlargement, and then the right ventricle enlargement, and the right atrial enlargement. So there's kind of as well two more definitions of heart failure to understand. Um, there's systolic dysfunction, which is a decrease in contractility, and so you have your lowered ejection fraction. Um, your diastolic dysfunction, which is referring to decreased compliance. Compliance is, you can think about that as the ability of the heart to stretch and fill. So kind of think about like the Starling forces. Your heart relies on the ability to expand in order to generate force. So if the heart is not able to kind of get that stretch, it's not able to adequately fill. So what happens is you get increased pressure um, just to maintain the normal volume that it needs to provide an adequate cardiac output. And you'll see a preserved ejection fraction. Whereas a systolic dysfunction, because it has that reduced contractility, it has reduced ejection fraction, and it's trying to compensate by putting more volume in. So it's actually enlarging the ventricle as a result. Both of these conditions can result or can occur in both left and right sided heart failure. And here's two graphs here that are showing kind of the two difference in the systolic and the diastolic dysfunction. But I know it says HFrEF and HFpEF. These two terms I'll cover later, but they're exclusively referring to um, ventricular, the left-sided heart failure, just because ejection fraction has to do with the left ventricle, not the right ventricle. But you can see here when you decrease the contractility. So this is right here. This is the normal shape of a pressure volume loop referring to your heart pressure and volume. But when you decrease the contractility, the slope of this line decreases, as you can see right here, this pink one. So what does that do? That's going to increase your pressure. So this pressure goes to here, which is the beginning of ventricular contraction. And so ventricular contraction, and then here's where the aortic valve opens, and then the volume decreases as it goes right to left, and then here's where the ventricular contraction ends, and the pressure drops, as you can see, and then ventricular filling occurs again, and it just keeps going in a cycle. But that's what happens right here. As you can see, they have increased pressure and increased volume. As you can see, it moves from over here to over there. And then over here, for the diastolic dysfunction of HFpEF, what you're going to see is the same volume, because it has not translated to on the x-axis. It's actually translated on the y-axis, or y-axis, because of the decreased compliance. So you're going to have higher pressures overall. Yeah, so there's a classification system done by the American Heart Association and the American College of Cardiologists. And it's HFrEF and HFpEF. And there's like two other classifications that aren't really important to know. The important two are HFrEF, which is heart failure with reduced ejection fraction. It's defined as left ventricular ejection fraction less than 40%. And then HFpEF, which is left ventricular ejection fraction, which is 50% or greater. And we're just going to call it 40% for the purposes of school. And so, yeah, it's kind of going back to what the previous slide was talking about, the diastolic failure. The left ventricular is stiff and cannot relax during diastole. And yeah, it's going to result in increased pressures with exertion, and you can't meet the metabolic demands during exercise. And again, both of these terms refer to left heart failure. So here's an echocardiogram of HFrEF. So I wish that would just keep playing. But anyway, you can see the chambers of the heart. This is peristernal long. So you're putting your probe on top of the chest, kind of mid-clavicular, and the probe point is pointing towards their right shoulder. So what you're going to see is right ventricle, left atria, and then here's aortic valve into aorta, and this is mitral valve. And you can see how dilated the left ventricle and the left atria are. They should not be this enlarged, especially in comparison between the left ventricle and the right ventricle. There's a huge difference between the two, so you can see. And then here's peristernal short. So you turn the probe 90 degrees from where you had it in peristernal long. And now you can see significant dilation as well here. And then this is apical. So you kind of have this looking like, if you were thinking about EKG placement, this is sort of where V5 is. It's looking up to the right shoulder, right up to the right shoulder as far as the direction of where the bottom of the probe is looking. So the probe is still pointing towards, or the probe is now pointing towards patient's left shoulder. So this should be left ventricle, left atria, right atria. And you can see again, all four chambers are enlarged at this point. You can see how big they are. So here's another definition of heart failure, and this is important because it's a functional definition. It's the New York Heart Assessment. I believe that's what it stands for. It's New York something. But anyway, there's four classes, 1, 2, 3, 4, and they elevate. In terms of severity, you can see right here the 1 year mortality goes from 5 to 10% in class 1 and 2, all the way to 10 to 25% in class 3 and 25 to 60% in class 4. So class 2 is a mild limitation on your physical activity. You're able to do your normal physical activity, but you get a little bit of fatigue or palpitations or dyspnea on exertion or angina. And then class 3, you kind of go up the scale. So you're not able to do any of your normal physical activity. You're doing less, but you still have all those symptoms as well. Class 4 is very severe. This is really bad. This is when you can't do any physical activity without becoming symptomatic, um, as well as you have symptoms of uh, cardiac insufficiency at rest. It just increases when you do physical activity. So any physical activity is bad. Any or the lack of physical activity, you still have problems. So this is really bad. You're probably, if you're, we'll get to it later, but you're probably getting towards that device implantation intervention stage, if not a full-on heart transplant. And this classification is assessed on each visit and documented, and it can change depending on how they're doing or not doing well. His general history, typical stuff, nothing outside of the normal that you wouldn't want to know. Prior history of heart failure, cardiac diseases, illnesses, pregnancy, social history of substance abuse or toxin exposure, as well as any family history. Physical exam, pretty logical stuff. If you have right-sided heart failure, you're going to have peripheral edema, as well as hepatomegaly, so your liver is going to be enlarged, as well as increased jugular venous pressure because the fluid is backing up into your venous system, as well as you might hear tricuspid valve regurgitation because you have such overloaded chambers of your right side. Left-sided heart failure, again, logical stuff. You're going to hear crackles and rails in the lungs because your left side is failing. It's backing fluid up into your pulmonary vasculature. You might hear a respiratory wheeze. You're going to have a displaced cardiac apex, so where you're able to feel on your chest kind of like that vibration of your left ventricle going, it's going to move because your left ventricle is enlarging, so it's going to move. You'll also have left-sided murmurs similar to how you have tricuspid valve regurgitation in the right side. You'll have left-sided murmurs and left heart failure. And then kind of just general findings between both of them. Cool extremities, peripheries, because you have poor cardiac output. Cyanosis, again, same thing. Orthopnea, so like if you lay on your back, you're going to get short of breath. Delayed capillary refill, again, having to do with being able to provide circulation to your body. And then tachycardia, because your heart's trying to compensate for its decreased stroke volume. So again, like I said, left heart failure, pulmonary congestion, and edema. You'll have just edema in the interstitial spaces and just where your pulmonary vasculature and lymphatics are. And those spaces are going to get wide, so your alveoli are separated by spaces. Those spaces are your alveolar septa, and they're widening from edema, as well as you'll have this histopathologic sign. It's called heart failure cells, hemosiderin-laden macrophages. They basically ingest all these red blood cells and plasma proteins that are getting into your alveoli, and they're ingesting them, and then the iron is stored as hemosiderin, and then you see it on the slide. It's these things, and they will represent previous pulmonary edema. Right heart failure, like I mentioned before, you'll have backups of into your venous system, so your liver will become enlarged, and it'll get this thing called cardiac cirrhosis or nutmeg liver, which is this thing that doesn't really look like nutmeg to me, but it's brown, I guess. I mean, nutmeg just looks like a nut to me. I don't know, but that's nutmeg liver. You'll have jugular venous distension, increased pressure, and then peripheral edema, of course, pitting edema. We know what that looks like, where it gets all fluffy and then press in, and then it just stays depressed. Here's some imaging options for heart failure. The gold standard is a transthoracic echo, an echocardiogram. And then you have several other options. You can do a cardiac CT, which is a non-invasive assessment. You can do an invasive assessment, which is cardiac catheterization, which I'll talk about next. And then cardiac MRI is very detailed, also very expensive and time consuming to do. But you can see really in-depth details about scar tissue, fibrosis, edema, and infiltration. And then you have nuclear imaging, a PET scan, or multi-gated acquisition MUGA, which is able to assess for ejection fraction and inflammation. And you can see that down here. So yeah, here's another set of staging by the ACC and the AHA. And this is important because it's kind of helping you decide how they're doing as a whole. I know the functional assessment from the New York Heart, the NYHA assessment scale also gave you a functional idea of where they are. But this is kind of helping decide how they're responding to treatment, I guess, or where they are as far as what level of intervention we need to take. So stage A is, they're at high risk of it because they have hypertension, they have coronary artery disease, they have diabetes, they have a family history. B and C is where you start intervening with medications to try to reduce their chances of going to higher stages. And you can see here that's they're asymptomatic, so maybe they're class 1 on the NYHA functional assessment, but they have previous MI or left ventricular systolic dysfunction or valve disease, or they are symptomatic and they are now stage C. So both of those are kind of treated the same. Stage D is when they are not responding to medical therapy, and that's really bad. That's when you start getting down to the pacemakers and other device therapies. So how does this? What's all the problem? What's occurring here? The problem is you have this adverse myocardial remodeling, and what is this caused by? The sticking point. That's your sympathetic and RAS activation. So sympathetic system, we know what that is. That's your fight response in your nervous system. Your RAS system, that's your renin-angiotensin aldosterone system. That's in your kidneys. That activates when your body senses that you have low blood pressure, and it goes, oh, okay, hey, we need to retain fluid because we have low blood pressure. So it's going to start pulling certain ions back into your body, or other substances that you would normally excrete to pull water into your body to maintain your blood pressure. So it's going to activate it. That's bad. That's what's causing problems and exacerbating the situation. So the start of it, I guess you can really get to, is you have some sort of myocardial insult. So like somebody has a heart attack and they have ischemia and resulting infarction and death and fibrosis, and now their heart doesn't really work perfectly. So now they have this cardiac dysfunction that causes this hemodynamic decompensation. So they're trying to now compensate for that by having the activation of the RAS system. They release catecholamines and endothelin, so that's your sympathetic system activating as well. And now your renal system is activating to retain fluid, like I explained earlier, and that's resulting in you're now experiencing increased preload and also higher afterload, and it just kind of cycles around itself, and you get the left ventricular remodeling, where if you remember back in the anatomical display of the left heart failure and the right heart failure, where your ventricles expand to compensate. So that's kind of the general idea of what's going on and causing the problems. So then we have GDMT, guideline directed medical therapy. There's 4 elements to it. The first one is beta blockers. The second one is either an ACE inhibitor, an angiotensin receptor blocker, or an angiotensin receptor neprilysin inhibitor. You choose one of those 3 in pillar 2. And then pillar 3 is your mineralocorticoid receptor antagonist. Pillar 4 is your sodium glucose transporter 2 inhibitors. You may be asking, what are these? Well, you obviously know your beta blockers are. Beta blockers. That's your carvedilol, your bisoprolol, all your lols. Metoprolol is a big one. Your mineralocorticoid receptor antagonist, that's your spironolactone. That's probably going to be your most common one. And then your SGLT2, that's all your pagliflozins, your empagliflozin, dabigliflozin, aka Jardians. That's a big one. That's your brand name. So if you see Jardians, that's their SGLT2. And then your ACE inhibitors and ARBs and ARNIs. So your ACE or your ACE inhibitors are your prils. So most common lisinopril. Your ARBs are going to be your sartans. So losartan and valsartan are probably going to be your most common ones. And then your ARNIs, that's a combination sacubitril and valsartan. So you choose one of these. And the only reason why, well, not the only reason why, but I think your ACE inhibitors are not so popular, again, because they have that really nasty adverse effect of that dry cough. So they try to avoid giving somebody that when they have some sort of respiratory disease, because they'll have a cough and then they go, oh, what's the cause of it? Is it respiratory or cardiovascular or medication related because you have an ACE inhibitor? So they don't try to give you ACE inhibitors if you have some sort of respiratory disease. All right, and then you have some other drugs as well that you can give. Hydralazine isosorbide. That's your was it aldosterone antagonist? So try to control that blood pressure. Digoxin. Try to improve your contractility. It's for symptom improvement. Not really that popular, I don't think. Digoxin. I think that's like an older medication that if you had it, you probably still are getting it, but I don't know if they're still prescribing it now. Maybe they are. Who knows? Don't really see it that much. So yeah, if your GDMT is not working, you'll start going to device therapy options. So your ICDs, this is really just to prevent sudden cardiac death. So if they go into VTAC or VFib or whatever, it's not actually to improve how they feel symptoms, because obviously it's just there to cardiovert or defibrillate. So it's just to keep them alive. Your cardiac resynchronization therapy, that's a fancy word for pacemaker. I just inserted the pacemaker part myself because they didn't ever actually say that, but I'm pretty sure that's what it is. And there's your indications, ejection fraction less than 35%, so they're HFrEF. And then they're class 2 all the way up to 4, and they're receiving GDMT. As well as they're in a sinus rhythm with a left bundle branch block and a QRS of greater than 150. So they have some really bad ventricular dysfunction. And the goal is atrial synchronous biventricular pacing. And of course, it may or may not be able to defibrillate and cardiovert. And it does improve symptoms, and it does reverse cardiac remodeling, trying to stop your heart from adversely restructuring itself. So advanced heart failure. How do we know when we have it? So this is like, oh, these things are no longer working. Maybe we need to start thinking about heart transplant or LVAD. This is a helpful mnemonic to determine it. If you need inotropes, and then you look at what functional assessment are you in. Are you still in 3 and 4? 4 is really bad. We don't want you to be in 4. Also, if you have high BNP or NT-proBNP, which is a biomarker that is indicative of your left ventricle stretching. So you're still undergoing that adverse remodeling. And organ dysfunction because your renal or liver system is not working, because your heart is not working properly. If your ejection fraction is really low, if you keep getting shocked onto your defibrillator, also not a good sign. If you've been hospitalized, also not a good sign. If you have all this edema and you keep getting diuretics to try to reduce it, also not good. We'll talk about that because that's also another intervention. Hypotension is also not good. We know that. If you're hypotensive, you're not doing so good. And then if you're kind of maxed out on your medical therapies and they're not really having the effect that they want, also really not a good sign. So there's a few functional assessments they could do: a 6-minute walk test, exercise stress test to try to see what your oxygen consumption is when you're doing a certain physical activity, and then VO2 max determination. And then there's a really invasive assessment, which apparently they don't really do much anymore. Using a Swan-Ganz catheter, your right heart catheterization, So you're looking at all the pressures in the heart, your right atrial, right ventricle, your pulmonary artery, your pulmonary capillary wedge pressure, which is a substitute for your left atrial pressure, your cardiac output and your cardiac index, and then your vascular resistance, systemic and pulmonary. And then you have kind of three different stages of heart failure. You have stable heart failure, where you're just going to hear your GADMT, and you might get one of the devices, defibrillation, um, or a defibrillator. You might get revascularized, or you might try to change the rhythm that they're in. Um, then acute decompensated heart failure, and that's treated with your diuretics, so trying to reduce that fluid. And your cardiogenic shock, that's when your heart is not able to provide adequate perfusion, and they really that's pretty concerning, and we'll go into that in detail. But first, acute decompensated heart failure. So here's some possible causes of it: medication interaction. You're not giving enough medication. They've got hypertension, rhythm disorders, your AFib, uh, and infection or lung and kidney disease. And you're going to look at their functional class, do your physical exam, do all the imaging, check what rhythm they are on your 12 lead, and do your BMP and troponin. And then your therapy is going to be diuretics to reduce the preload and afterload reduction as well, using vasodilators, nitroprusside or nitroglycerin. If you have to, because they have inadequate perfusion, you can give them some inotropic agents, but that's also really, that's kind of like a temporary measure. It's very severe if you're having to give them inotropes. But yeah, as far as diuretics you can give your loop diuretics, your thiazides, and acetazolamide. So cardiogenic shock, yeah, I don't know why they say cardiogenic shock and then they identify the shock, and then they listed all the different types of shock. Very strange, but whatever. Yeah, identify the cause. If they have an MI, arrhythmia, yeah, fix the AFib, RVR. Infection. Your treatment here is going to restore the perfusion and improve in organ function. And then, yeah, you might have to go to the advanced heart failure therapies, which is transplant or LVAD. So, yeah, there you go. If they're in cardiogenic shock, you give them inotropes to help their heart out. If they're hypovolemic, give them fluids or blood. Distributive, give them inotropes and pressors. Obstructive, relieve the obstruction. And then here's some definitions of what shock looks like. I think as far as the medics, we can kind of figure that out. That's pretty self-explanatory. Other than cardiac index, that's a different one. But everything else here, understandable, right? Like decreased mentation, cold extremities. I don't know what this is. Low urine output because your renal system is no longer getting adequate blood flow. Lactate because you're anaerobically metabolizing stuff. And yeah, here's all your pressors and inotropes here: dopamine, dobutamine, norepi, epi, milrinone, vasopressin. And again, yeah, they're meant for short-term support because they increase the myocardial oxygen demand. So they're kind of that last resort cardiogenic shock. Hey, we need to support the heart, even though it's going to increase the demand. It just needs a little bit of a boost to try to stabilize them. So if they're in that end stage of heart failure, here's some cardiac support devices. So an intra-aortic balloon pump, kind of moving the blood around to help perfuse the coronaries. Impella to move blood from chamber to chamber, or chamber from left ventricle into the aorta. The tandem heart, literally working along another. It's literally another heart, I guess. Not really another heart. It's really literally another pump, moving blood around to help get it out of the left side into the aorta. And then ECMO, taking the heart completely out and doing everything on the side, bypassing the lungs and reoxygenating their outside. Pretty significant intervention when you have both sides are failing to do ECMO. And then yeah, here's your device therapy, your LVADs. We know what those are. They got the external battery pack to to put on there in the left ventricle and help push fluid out into the aorta. And then a whole cardiac transplant, replace the whole heart. There's two different ways to do it, biatrial and bicable. Don't ask me what the difference is exactly between the two other than where you cut it. But yeah, cool. And here's some indications for cardiac transplantation. The big ones are they're in HFrEF and class 4 functional, and they're refractory to GDMT, and they are scoring very poorly on these survival scores. Some contraindications are they don't really see them living too long. If they have too much pulmonary hypertension, they're actively using substances. They don't have a support network to help them, take the immunosuppressants so they don't reject the heart. And then, yeah, here's some other relative contraindications as well. But here's another recent new innovation within the past year or two, is the Bivacor. It's a total artificial heart replacement. And this is for people who are not LVAD candidates, but they're still waiting for an actual heart transplant. So this is literally the device that goes into them, and then it does everything. It still requires a battery, or external battery. You can see the cable running out. But pretty cool. ACC-AHA stages with the interventions. So just kind of going back to what I was talking about, stage A where you're kind of that high risk, and then stage B and C is when you start loading on the GDMT. And then as you get worse, it's that stepwise approach. You start intervening more with interventions, and then you get into devices as well. And then, stage D is when you really need to break out the inotropes and pressors, maybe consider an LVAD and transplant. And if it's to the point where nothing is really working at that point, that's when you go into that palliative care of hospice. So, yeah, that's apparently that's it. So thanks.